Hey guys, in this video, I'm going to be talking about when to use IV fluids, the different types, how much, how frequently you should give them, as well as some high yield physiology about fluid compartments, manipulation of hemodynamics by the fluids, and some clinical pearls. Should be useful for step one, step two, and your clinical rotations. So before we dive into IV fluids, let's talk a little bit about the fluid compartments. So fluid compartment physiology 101, you have two things. Well, you have your extracellular fluid and you have your intracellular fluid. The extracellular fluid consists of plasma and interstitial fluid. Of that, 3/4 is your interstitial fluid and 1/4 is plasma. It's pretty easy to memorize, but can you really visualize what we're talking about here? If you look at the picture on the left, the volume of fluid in the capillary, in the vessel, that's your plasma. That's separated by a membrane that borders tissues where the cells are. And the purple circles, those represent the many jillions of cells in your body. The fluid inside the little purple circles, that's your intracellular fluid, right? Makes sense, inside the cell. And anything that's outside of the cell, by definition, would therefore be extracellular fluid. And I highlighted that in yellow. That's just the space where the cells are not there. That's just space, and that's where the interstitial fluid sits, and plus the plasma, which is in the vessel. That's your extracellular fluid. Now, keep in mind that the cells have their own membrane separating them from the interstitial fluid. So let's say we just drew some blood, put it in a tube, checked it out under the microscope. The fluid inside the red blood cells that you'll see, that's your ICF. And the cells, what are they surrounded by? Plasma. Makes sense, right? We just took the blood out of the vessel. So let's go ahead and define these terms a little bit more. So the plasma and interstitial fluid is separated by a pretty thin membrane. What that means is that the concentration of the ions in these two places is pretty similar. An important difference between them is that the plasma has a lot more protein, albumin. And why is that? That's because the capillary membrane is not permeable to proteins. The intracellular fluid and the membrane that separates it from the interstitial fluid is only permeable to water. Okay. Now, there's some key differences between the constituents of these compartments, so let's talk about them now. So this is a little chart I got from a physiology textbook, and it separates the different compartments, plasma, interstitial, and intracellular. And if you notice, the sodium and chloride is much higher in the plasma and interstitial fluid. The K is super fucking low relative to the intracellular fluid. And if you look, the bicarb is also lower in the plasma and interstitial fluid versus the intracellular fluid. The other thing I want to point out is the differences in protein. Protein, it's higher in plasma and highest in the intracellular fluid inside the cells. And also, check it out. The osmolarity, is about the same. In other words, the tonicity, the concentration is the same in these compartments, all three of them, and that assumes that these compartments are in equilibrium. And of course, we know that's not always the case. So let me ask you a question: where have you seen the values in plasma and interstitial fluid at the hospital? You see them in your chemistry panel. That's what they're talking about. So your chem panel that you order is talking about these values in these compartments. Okay, next I want to introduce this concept of effective circulating volume or effective circulating blood volume. Okay, it's by definition the volume of the fluid in the arterial system that maintains tissue perfusion. This is the money variable we manipulate with fluids. It's dynamic. We're talking about the ECF here, okay? And we have sensors in the body that actually don't detect changes in volume. They detect changes in pressure, which is influenced by volume. And what are they? We got the afferent arteriole and the kidneys. We got the carotids, the heart, the atria, and the ventricles. So these sensors detect changes in pressure. And what are they influenced by? They're influenced by volume, cardiac output, and vascular resistance. Now, I mentioned that IV fluids manipulate the volume. The other two important factors, cardiac output and vascular resistance, these are mainly manipulated by the sympathetic nervous system and the renin-angiotensin-aldosterone system. You're probably thinking, wait a minute, the fluids should also influence the cardiac output by means of preload, and the volume status should affect the renin-angiotensin-aldosterone system. And you're right, it does. But for simplicity and understanding how fluids play a role in all this, I like to think of it in this way. To further complicate this, I want to highlight a very important pitfall. Total body weight of water does not equal your effective circulating volume. What the fuck you mean by that, bro? So think about your patients with heart failure and cirrhosis. Despite them being fluid overloaded and having more volume, they're actually not perfusing that well. Your heart failure patients have poor cardiac output, and your cirrhotic patients have poor albumin. So even though they have more volume of fluid, they have a less effective circulating volume. and therefore they're not perfusing as well. One other thing I want to talk about is this hemodynamic formula in the green box. DO2, oxygen delivery, is equal to cardiac output, CO, times 1.34 times hemoglobin times O2 saturation times 10. The reason I bring this up is because oxygen delivery is the name of the game. That's what we're trying to accomplish here. And cardiac output, major determinant, and hemoglobin and O2 saturation. All of these things we can influence, we can manipulate to increase oxygen delivery. So I just kind of wanted to throw that out there as well. Okay, cool. So now we know some compartment physiology, hemodynamic factors, effective circulating volume, how IV fluids play into all that. Now let's talk about when the fuck do you actually use these fluids. You'd want to use them to resuscitate a patient that's hypovolemic, if the patient can't tolerate oral fluids, metabolic derangements, DKA, electrolyte imbalances, etc. General rule of thumb, if you can use the gut, you probably should. Also, if you add D5, that's going to give you some nutritional support. The glucose will prevent protein catabolism, but obviously that's not going to be the best and last forever. If the patient is not going to be eating for a few days, fluids won't be enough. You might have to initiate tube feeding. So you're either going to keep a patient afloat, just maintain them while they're inpatient. There's no actual identifiable deficit. This is going to be your patient that's coming in for some elective surgery possibly. So if you're not maintaining them, you're repleting them. You're fixing the volume or electrolyte imbalance, resuscitation, etc., things I mentioned above. I want to make a little point about maintenance fluid. Sometimes you need it, oftentimes you don't. And I'll give you an example. So let's say you have dinner at 7 o'clock at night, you go to sleep, you wake up 7 o'clock in the morning. Well, guess what? 12 hours later, nobody put an IV in you, nobody gave you fluids, and you're still alive. So if somebody's coming in for like an elective procedure, if you don't give them fluids overnight, it won't be the most detrimental thing. But yeah, sure. Maintaining their fluids will keep them optimized for surgery, give them some nutritional support overnight. So we talked about the indications and whether you're going to be maintaining patients or resuscitating them. The other prerequisite to giving fluids is assessing their blood volume. This is really, really important to do, and it sucks because there's no exact, precise, 100% way to do this, but there are a few factors that you should definitely consider when evaluating the need. Let's start with the vital signs. You should definitely check the vital signs. Is your patient tachycardic? Are they hypotensive? If they are, they're probably hypovolemic. Now, the caveat to this is that early on, they might not be tachycardic or hypotensive, so the sensitivity and specificity of these is not that helpful. Also, your patient might be on a beta blocker. What do you know? Postural changes to heart rate and blood pressure, like when the patient goes from flat to sitting up to standing, are a little bit more sensitive to moderate to severe loss. But let's be real, no one's going to do this at 3 o'clock in the morning, the level 1 trauma rolls in. So vitals, helpful, but not the total picture. The next thing you want to look at, lab values. So let's start with hemoglobin and hematocrit. You'd think, oh yeah, this would give me a good idea about how much blood someone's losing. But if someone just got stabbed and they're coming in, it would take a while before the hemoglobin kind of shifts, the fluids shift throughout the body to show a drop. Moreover, when you get stabbed and you lose in blood, you lose whole blood. That's going to be a proportional drop in RBCs and plasma, so the crit might not even move. What it's really good for is those relatively stable patients who have like a legit decline from their baseline. Then you know that you have to do some investigation. You can use hematocrit to kind of guide your resuscitation efforts. So let's say the patient's hypotensive, you gave them 5 liters of isotonic saline. Well, what's going to happen is you're going to pump up their plasma volume, but the RBCs will be low relative to the plasma. Your hematocrit is going to drop at the end of those 5 liters. You also want to check the lactate. A lactate of 4 or higher is associated with an increased mortality in ICU patients, indication of anaerobic metabolism. But you want to take that with a grain of salt. Some patients might not be able to clear lactate. They might have marginally elevated lactate levels to begin with. So the research shows that, yeah, if the lactate is normally 0 and it's 4, we have a problem. But let's say somebody has baseline elevated lactate levels. What you want to focus on is the rate of clearance. So let's say you got a patient with baseline elevated lactate levels for whatever reason. Now he's in septic shock, and you resuscitate the patient. You want to pay attention to how quick the lactate clears back to baseline, even though it's a little high at baseline. A quicker rate of clearance is associated with less mortality. That's really important. You can also assess the need for fluid with a fluid challenge. This is going to be your patient that's likely going to need fluids, shitty hemodynamics, labs look a little fishy. What do? You do a little bit of trial and error. There's no standard protocol set in place, but 500 cc's of isotonic saline over 15 minutes is a reasonable challenge. I want to highlight something important here. The rate of infusion is a little bit more important than how much you're actually giving them. We want to pump up the preload as fast as we can. But you've got to keep in mind that you don't want to drown your patients in fluids. Too much fluids, no bueno. Alternative to this, you can do a maneuver called the passive leg raise, where you lift the patient's legs up 45 degrees, and that introduces about 120, 300 milliliters of fluid into the heart. It's going to increase your preload, and if you notice an increase in pulse pressure when you do this, you might be onto something. The patient might benefit from some actual fluid. But again, let's be real. Are you really going to do this at 3 o'clock in the morning in your level 1 trauma who just got shot in the leg? Probably not, but definitely something to consider. So a key point here is that no one variable should be the sole determinator of fluids. Some have more sensitivity than others, but you want to look at the whole picture. Right now, the best way to assess blood volume is to kind of do a fluid challenge and see how the hemodynamics change. Invasive hemodynamic monitoring via arterial line become really important in these patients. The other thing I didn't really mention was the measurement of cardiac filling pressures, like a central venous pressure or pulmonary artery occlusion pressure. These used to play a pretty important role in calculating the circulating blood volume, but not really anymore because studies have shown that there's a poor correlation between cardiac filling pressures and end diastolic volume. So you don't want to use CVP to decide your fluid management. Okay, so now we decided we need fluids, we've assessed the blood volume, we know what the fluids are going to manipulate. Let's talk crystalloids and colloids. This is the meat. Let's start by defining these terms. A crystalloid is a solution where the components are uniformly dissolved throughout. More importantly, these components can diffuse through a membrane. If infused, they would move from the vascular space to the interstitial fluid and affect the circulating blood volume. Colloids, on the other hand, are suspensions. They have stuff in them that's not totally dissolved. If you make a smoothie with milk and protein and almonds and all that good stuff and you swirl it all together, and you let it sit for a while, that's a suspension. That's a colloid. It's not uniform throughout. If you take saline and you add some protein that's not dissolvable, that's going to be a colloid. That's going to be a suspension. And these molecules that are not totally dissolved in the suspension, what they do is they create something called oncotic pressure or colloid osmotic pressure. And this pressure influences the movement of fluid. So let's talk about what would happen if you infuse a liter of crystalloid versus a liter of colloid. So we talked about how the extracellular fluid consists of plasma and interstitial fluid, right? So let's start with the crystalloids. So let's say you gave a liter. First, it's going to end up in the vessels. Of that, 25% is going to stay in the vessels and be part of the plasma, and 75% will go into the interstitial space and be part of the interstitial fluid. Ultimately, both make up the ECF. So now let's talk about colloids. A liter of that is also going to first go to the vessels. It's going to be part of the plasma, but it's not going to go from the plasma to the interstitial space and influence the interstitial fluid. It's going to expand the plasma mostly. Remember I said that the colloids consist of components that don't totally dissolve and move from compartment to compartment, but they do generate oncotic pressure, which influences the movement of fluid. Okay, so crystalloids, we have isotonic saline, lactate ringers, lactate acetate, hypertonic saline, and dextrose solutions. For colloids, we have albumin, 25%, 5%, dextrans, and blood products. So the main electrolyte in ECF is sodium, and the main electrolyte in most crystalloids is sodium. Let's start with isotonic saline, aka normal saline, NS, 0.9%. Ironically, normal saline is not really normal per se. And what I mean by that is compared to plasma, there's way more salt, it's lower in pH, and it's actually a little higher in osmolarity. Despite that, normal saline will be your go-to fluid of choice for resuscitation, and I'm going to talk about why that's the case in a little bit. But let's say you infuse 1 liter of isotonic saline to a patient. 275 milliliters of that is going to end up in the plasma, which will affect your blood volume. 825 milliliters will eventually end up in the interstitial fluid. Wait a minute, 275 plus 825, that's a little bit more than the first liter we started with, right? Why is that the case? Let's look at that picture on the top right. So I said 275 will end up in the plasma. In other words, of that liter, 275 ended up staying in the plasma. 725 ended up going to the interstitial space. Because normal saline is hyperosmolar relative to the intracellular fluid, there will be a shift of fluid from the intracellular space to the interstitial fluid. That's where that extra bit of fluid comes from. But this is also the basis behind interstitial edema, a complication of infusing a lot of normal saline. So patients that need resuscitation often require more than 1 liter, often getting 3-4 liters of normal saline. That can actually cause hyperchloremic metabolic acidosis. The reason that happens is it's a little complicated, but you can look at it from a chemical point of view as well as a physiological point of view. I'll start with the chemistry. So there's something called the strong ion difference, which is a measure of dissociation of the strong cations and the anions. In chemistry, equations with charges have to be balanced. So the formula for SID is the strong cations, the strongest of which is sodium, and minus the strong anions, the strongest of which is chloride. For simplicity, you can omit the hydroxide because its concentration is relatively negligible. So normally, the sodium is 140 in plasma, and the chloride is 103 in plasma. If you do the math, that's 40. 40 plus some concentration of hydrogen is equal to 0. Infusing normal saline changes the values to 154 for each, and when you subtract them, you end up with 0. So the strong ion difference with normal saline will change to 0. So 0 plus some concentration of hydrogen should equal 0. If you look at those 4 rectangles at the bottom of the screen, the left 2 represent the compartments before an infusion of normal saline, and the right represents after an infusion of normal saline. Okay, so before the infusion, the line where the sodium ends, that's how much sodium you got. And the line where the chloride ends, that's how much chloride you got. That difference is the strong ion difference. Now notice you got a bit of bicarb there to kind of buffer the pH. After you infuse 1 liter of isotonic saline, the concentrations of sodium and chloride obviously increase. What this does is it decreases the strong ion gap almost to 0. If you look at the boxes on the right, which box actually got smaller? The bicarb, right? So in order to maintain electronegativity after increasing the concentration of chloride, the bicarb has to decrease. Because you're losing bicarb and you have too much chloride, that's why they call it hyperchloremic metabolic acidosis. That was pretty fun, right? Another way to look at it is from a physiological standpoint. Personally, I think it's a little bit easier. The left 2 boxes represent the compartments before an infusion of normal saline, and on the right, after an infusion of normal saline. So on the left, the electronegativity is 0. It's neutral. The charges are equally balanced. On the right, after you introduce all this chloride, you have a little bit imbalance, right? You have too much negative stuff outside the cell. Increase in negative ions in the ECF needs to be balanced in the ICF. So you have an intracellular shift of bicarb. It moves from the ECF to the ICF. There's less bicarb to buffer the pH. So what do you have? You have all this chloride, and you move some bicarb, aka hyperchloremic metabolic acidosis. Done. Next important crystalloid, Ringer's lactate or Ringer's acetate. Basically, it contains sodium chloride, potassium, and ionized calcium. Concentration of sodium and chloride is similar to that of plasma. It doesn't induce that metabolic acidosis you see with normal saline. So with the increase in calcium, some people worry that you can form clots with packed cells when given together. The other concern is that increased calcium might be a problem with patients on dialysis. The lactate and acetate, which are buffers to maintain the pH. The concern was that infusion of LR would increase the chances of lactic acidosis. We found that's not really the case, especially if the patient can clear lactate, and if they are getting lots of volume, it should make a huge difference. Some people still worried, so they add acetate instead of lactate sometimes. Also, you got to be careful when you draw blood from a patient who's getting lactate Ringers. You don't want to draw blood from the infusing catheter because that's going to give you a falsely super elevated lactate. Okay, next order of business, hypertonic saline. Obviously, more salt compared to plasma. It's better at expanding the ECF. So if you give somebody 250 mL of hypertonic saline, their ECF is going to increase by a little bit more than a liter. Where does that extra fluid come from? Intracellular shift from inside the cells because of the difference in tonicity. So you would think, oh, this is great for resuscitation. It's going to increase the ECF by so much, blood volume, etc., etc. But it turns out it doesn't increase the survival benefit compared to normal saline. And you're just going to dehydrate the shit out of the patient. Okay, now let's talk about 5% dextrose solutions. They are hypotonic relative to plasma, therefore their main job is cellular swelling. The dextrose provides a small source of energy, and once the dextrose is metabolized by cells, the osmolarity of D5 solutions is similar to that of plasma. In other words, the effect of dextrose is relatively short-lived. Infusing a liter of D5 is going to increase the intracellular fluid. If you give a liter, about 650 is going to end up inside the cells. Hashtag cellular swelling. Okay, so if you add D5 to normal saline, which already is hyperosmolar relative to plasma, you increase the osmolarity of that solution even more. Sometimes this is needed in the clinical setting when you're treating hyper or hyponatremia. Okay, so once you add D5 to NS, you have a solution that is hyperosmolar relative to plasma. So once you infuse this, what happens is the fluid moves from the cell to the ECF. That's going to cause cellular dehydration. So key point here, D5 by itself is going to cause cellular swelling, whereas D5NS will cause cellular dehydration. The other concern is lactate production and hyperglycemia, so just be careful with your diabetics. Okay, cool. Now let's talk about colloids. As I mentioned earlier, colloids are basically suspensions. They are not uniform throughout. They contain large molecules that do not pass from the plasma to the interstitial fluid. What happens is these molecules generate something called an osmotic force or oncotic pressure. Let's talk about this some more. So to determine the direction of flow in a capillary, you have to consider the oncotic and hydrostatic pressure. The hydrostatic pressure is P sub C. That's going to want to push fluid outside the capillary, and you want to subtract the oncotic pressure, which is the pressure that would want to pull fluid inside the capillary. So under normal conditions, if a patient is just laying flat, not doing anything, the hydrostatic pressure is going to be about 20 millimeters of mercury, and the oncotic will be 30 millimeters of mercury. Subtracting the two, you get minus 10 millimeters of mercury. In other words, at baseline, there is a net movement of fluid inside the capillary. A patient with low albumin will have low oncotic pressure, and therefore there will be a net movement outside of the capillary into the interstitial space, causing that edema. And the opposite is true. Infusing albumin is going to increase the oncotic pressure and fluid inside the capillaries. Albumin is a very commonly used colloid infusion. As I was saying, it increases the osmotic pressure. That's going to increase the movement of fluid inside the capillaries. It's going to expand the plasma. 5% albumin increases oncotic pressure by about 20 millimeters of mercury, and 25%, which is just 5% plus normal saline, that's going to increase it to about 70 millimeters of mercury. So looking at this from an academic standpoint, you'd be thinking, yo, albumin is a pro at increasing the effective circulating volume, cardiac output, et cetera, et cetera. But it turns out it actually doesn't improve the survival in patients who are hypovolemic. Just for completion's sake, I want to talk about hydroxyethyl starch and dextran solutions, which are two other types of colloid solutions. Okay, so hydroxyethyl starch contains long chains of glucose polymers, and dextrans contain glucose polymers, but they're just made from bacterium that's grown in sucrose medium. Hydroxyethyl starch metabolized by amylase in the blood. Both of these increase the oncotic pressure, they increase the plasma volume, similar to that of plasma, but they suck. They have so many cons. Hydroxyethyl starch can be nephrotoxic, can decrease hemostasis, increase amylase levels, and dextrans can increase bleeding, fibrinolysis. They can interfere with RBC transfusions, increase ESR, and even cause osmotic renal injury. In other words, probably not the answer, not really used. Don't pick it, bro. So you're probably thinking, this fucking guy wasted all my time with all this physiology, different types of fluids, but what the fuck do I use in real life? What do I use when I made the decision that the patient needs fluids? Going back to an earlier slide, you're either going to be maintaining the patient or you're going to be repleting them. So figure that out first. Figure out what you're going to be doing. Once you figure out the goal, you want to consider the deficit, the rate, what fluid you're going to use, and possibly additives. Let's start with the deficit. So this is really based on a clinical assessment. You can use vital signs, labs, physical exam, fluid challenge. There's also formulas to estimate the fluid deficit, but you're not going to be doing that when you have 5 minutes to figure out what to do, right? The next question you want to be asking is rate. How bad is it? Severe hypovolemia, hit them with 1 to 2 liters bolus until you see some improvement of increased tissue perfusion. The rate of IV infusion should be more than the amount of fluid that's being lost. Be sure to be monitoring the hemodynamics by way of arterial line or urine output during this time. Then you want to figure out what type of fluid you're using. Generally speaking, resuscitation, you're going to use a crystalloid, lactate ringers, or normal saline. More on that in a little bit. Then you want to consider additives. Does the patient need sodium, potassium, bicarb in addition to the fluids? I'm going to talk about sodium in a little bit more detail, but generally you want to start by assessing the fluid status. Is the patient overloaded, underloaded, and then you want to see if it's high or low, and you want to see if it's been going on for over 48 hours or not. You can add potassium as well, but you want to see if there's any concurrent etiologies like decay or anything like that. When you do add potassium to the fluids, the rate of infusion of the potassium is obviously a little bit slower than just giving IV potassium. Bicarb infusions are generally not needed unless there's severe acidosis. I'm talking less than 6.5, or if there's persistent GI loss. You want to add D5 if the patient is hypoglycemic, might have some type of nutritional deficiency like with alcoholics, or if there's some type of ketoacidosis going on, or if you're correcting electrolyte imbalances like with sodium. You do not want to give it to your hyperglycemics, obvious, your bad diabetics, and if the K is super low. Let's talk about sodium a little bit more. It's really important. If the patient is hyponatremic, the next step to do is assess their fluid volume. Are they overloaded, euvolemic, or hypovolemic? After that, you're figuring out the etiology and addressing it. If the patient is hypovolemic, you want to figure out why they're having this hypotonic loss. The first thing you want to do is correct the sodium, resuscitate with normal saline, and then you want to figure out the free water deficit. You can figure that out, and then you can divide that over X amount of time and infuse that slowly. You do not want to correct over 0.5 milliequivalents per liter per hour. Same idea for euvolemic patients, just figuring out why they're having this free water loss, and you want to replace the free water. Maybe they have diabetes insipidus. And if they're hypervolemic, this is usually the case with patients who got too much hypertonic saline. Just monitor the renal function, consider diuresis, and you want to look for other things like hyperglycemia, etc. Hyponatremia, same thing. You want to first check out the fluid status. Is it low, normal, high? Then you want to check the urine electrolytes with sodium and osmolarity, very important. This helps you figure out where the problem is. Is it at the kidney or somewhere else? So let's say that their patient is hypovolemic and they're peeing out tons and tons of sodium. That means they're losing their sodium to the kidneys. The kidneys are the problem. The next question, is the patient altered or not? If they're altered, hypertonic saline. If they're not altered, give them isotonic saline. If the patient is hypovolemic, you're still focusing on the kidneys, but you're assessing their ability to concentrate the urine or not. So if the kidneys lose their ability to concentrate urine, it's going to be hypoosmolar urine. And the next question to ask is there altered mental status or not? Same principle. If they're altered, you give them hypertonic saline plus or minus Lasix. And if they're not, you can just restrict their fluid intake. So in the case of hypervolemia, next step is, again, you check out the renal function. If the renal function is fine, then you look for other causes like heart failure or liver failure. But acutely, you're assessing the need for hypertonic saline. And you do that by checking if the patient is altered or not. Key point, you do not want to correct the sodium above 10 to 12 milliequivalents over 24 hours. You do this, you're going to fry their brain, you're going to get sued. So with hyponatremia, the real focus is, does this patient need hypertonic saline or not? Another point of confusion is, okay, so let's say they do need it. How much and how often? A lot of calculators for this on the web, but generally it's the patient body weight times the goal increase rate, which is about 0.5 milliequivalents per liter per hour. And don't forget that you need a central line. I stress the importance of not correcting the sodium rapidly. The only time it's sort of okay is if the electrolyte imbalance has been present for less than 48 hours and the sodium is above 120. To be honest, I'll always correct the sodium slowly and check the labs frequently. This is more for those fantastic academic questions. This is a very painful thing to memorize, and honestly, you're going to find this chart taped somewhere in the ED or the medicine floors. It's just something you have to do often. I know I talked a lot, but I'm going to leave you guys with a summary about when to use what fluid. If your goal is volume resuscitation, you want to give a crystalloid. You can either use normal saline, lactate ringers. Dr. Francis Moore published a paper in 1965 where he highlighted the importance of resuscitation of the interstitial volume with lactate ringers and how it improved mortality in hypovolemic patients. Since then, there have been plenty of other studies, and now we focus on increasing cardiac output and O2 delivery. The Crystal study from 2013 showed that among ICU patients, there was no benefit in mortality in 28 days between using colloid or crystalloid solutions. The Surviving Sepsis campaign recommends the use of crystalloids and balanced resuscitation. Don't ever use starch or dextrans. Next question is, which crystalloid is better, lactate ringers or normal saline? The SALTED trial of 2018 showed that there was no real difference between LR and NS, aside from the less risk of kidney injury with lactate ringers. Remember, we discussed the differences in composition, but the real issue with normal saline is that you need a lot of it to really amp up the ECV. Nonetheless, normal saline is often the preferred fluid of choice for resuscitation. The other thing is that normal saline is really cheap. Personally, I think the thought of money dictating someone's survival is fucked up wrong. Everyone should have access to the best whatever the fuck they need. But I digress. Colloids, not really used first line for resuscitation, but you can consider it if you think that maybe hypoalbuminemia is contributing to the shock. And again, albumin is a choice. Don't ever pick the starches or dextrans. Blood products, I think, are similar to colloids, but I give it its own section, and the use of that is pretty self-explanatory. Okay, last slide. I just wanted to touch upon some basic standard protocols and the goals of treatment. So resuscitation, like I said, crystalloid, you can use normal saline or LR. The goal is to maintain a mean arterial pressure of 65. That ensures adequate tissue perfusion. If they're bleeders, you need PRBCs. The threshold for that is less than 7, 9 if they have cardiac disease. And for platelets, the threshold for that is less than 50K. And for every 5 PRBCs, about 5, you would want to give some platelets. I want to talk about the importance of permissive hypotension. This is kind of saying okay to a little low blood pressure while you control the bleeding first. This has been shown to increase survival and lower the fluid resuscitation. You don't want to drown your patients in fluids. Finally, you want to keep your patient warm. Warmer temperatures have been associated with less mortality. The goals. Let's talk about the goals. How you know that what you're doing is working. You want to keep an eye on the cardiac output. You want to maintain a MAP of over 65 millimeters of mercury. You want to watch the urine output. Make sure it's at least 5 cc's per kilogram per hour. You want to ensure adequate O2 delivery. How are you going to check that? You want to ensure an O2 saturation of 88% or higher. You want to make sure the hemoglobin is above 7 or 9 for your cardiac patients. Aside from the O2 sat and hemoglobin, you can keep an eye on the SvO2, keep it above 70%, and watch the lactate clearance. And finally, you want to stop the bleeding. You want to normalize the coags. So that's all I got to say about fluids. This should help you guys navigate through questions and help you out on rotations. I hope this video was helpful. I would really appreciate it if you liked and subscribed. Of course, if I made any mistakes, there's any updates or I missed anything, just let me know. Thanks.